Today, let's discuss oncocytic thyroid tumors with papillary architecture, a topic that remains challenging and controversial. Pathologists frequently disagree on the diagnosis. However, accumulating evidence has helped build consensus regarding the nature of this uncommon entity. In this first image, we see a well-circumscribed, encapsulated thyroid tumor. No capsular or vascular invasion is identified. On high power, the tumor is composed of oncocytic cells with abundant eosinophilic granular cytoplasm. The nuclei are predominantly round, with occasional large, centrally located eosinophilic nucleoli, highlighted in the red circle. Careful examination shows focal nuclear membrane irregularities and nuclear grooves, red arrows. In another field, we see well-formed papillae lined by similar oncocytic cells. Summary of findings. This is an encapsulated oncocytic neoplasm. There is no invasive growth. Papillary structures are present. There is focal nuclear membrane irregularity and grooves. This raises the question, is this a papillary thyroid carcinoma oncocytic variant? This second case is another encapsulated tumor with a thick capsule and no invasion. At scanning magnification, numerous papillae are evident, suggesting a tumor with a predominantly papillary growth pattern. On high power, we again see an oncocytic neoplasm with abundant granular eosinophilic cytoplasm. The nuclei are round and dark, not the classic PTC nuclei with pale chromatin. This another look of the same case. The tumor cell nuclei are round and dark, not the classic PTC nuclei with pale chromatin. Within the circled area, we see focal nuclear membrane irregularity, nuclear grooves, and prominent central nucleoli. Morphologically, this tumor closely resembles the first case. It is an encapsulated oncocytic neoplasm with papillary structure and nuclear membrane irregularity and nuclear grooves. Again, we ask, is this an oncocytic PTC? The diagnosis is oncocytic adenoma. Various terms have been used, including encapsulated papillary oncocytic neoplasm. Although descriptive, this term was ultimately not adopted in the WHO classification because it caused confusion. In the current WHO system, these tumors are categorized under oncocytic adenoma, with a note that oncocytic adenoma with papillary architecture should not be diagnosed as PTC. If you previously diagnosed such cases as oncocytic PTC, you are not alone. Studies show that about 50% of pathologists make the same call. This reflects the difficulty of the diagnosis. In thyroid pathology, papillary architecture tends to create an automatic association with PTC. One study found that 14 of 19 such cases were diagnosed as oncocytic PTC. Even today, expert thyroid pathologists split nearly evenly. Half call these cases PTC, and half call them oncocytic adenoma. However, more and more studies have confirmed the benign nature of these cases. Oncocytic adenomas with papillary architecture are rare and occur in patients aged 14 to 86. All reported tumors were encapsulated and cytologically identical to oncocytic adenoma, except for the presence of papillae, which can be focal or diffuse. Typical tumor cell features include round nuclei, dark chromatin, large centrally placed nucleoli. These differ from PTC nuclei, which show pale chromatin, oval nuclei, small nucleoli often adherent to the nuclear membrane, and diffuse, not focal, nuclear membrane irregularities and grooves. These tumors also differ from PTC at the molecular and immunohistochemical levels. BRAF mutations is absent in all cases. HBME1 is negative in all cases. CK19 is negative in all but one case. For difficult cases, CK19 HbME1 and BRAF testing can help support the correct diagnosis. All non-invasive cases behave benignly, with no recurrences or metastases on long-term follow-up. Its malignant counterpart is oncocytic carcinoma. Just as in conventional oncocytic adenoma, malignancy is diagnosed only when invasion is present, either capsular invasion or vascular invasion. In the example shown, the encapsulated oncocytic tumor with papillary architecture shows capsular and multiple vascular invasion, diagnostic of oncocytic carcinoma. High power again shows abundant eosinophilic cytoplasm, round, dark nuclei, and large central nucleoli with focal membrane irregularities and grooves. This slide compares the nuclear differences between oncocytic adenoma and oncocytic PTC. Oncocytic adenoma have focal nuclear membrane irregularity and groups. The nuclei are predominantly round with centrally located large nucleoli, while oncocytic PTC has widespread PTC nuclear features, including a combination of nuclear enlargement, crowding, pale chromatin, with oval-shaped nuclei, nuclear membrane irregularity, inclusions, and grooves. The rule of thumb is that if the tumor is truly oncocytic, with abundant eosinophilic cytoplasm, round nuclei, and large nucleoli, then focal membrane irregularities and grooves should not be overinterpreted. Oncocytic PTC shows widespread PTC nuclear features. There is no need to hunt for them. If you find yourself unsure whether the nuclei qualify as PTC nuclei, the tumor is almost certainly not PTC. Conclusion: oncocytic adenoma with papillary architecture is frequently misdiagnosed as oncocytic PTC. For oncocytic tumors, malignancy is defined by invasion, not by papillary growth or scattered nuclear abnormalities. These tumors are HbME1 negative, usually CK19 negative, and BRAF wild type, supporting their distinction from PTC. Therefore, when a tumor is oncocytic, focal nuclear membrane irregularity and grooves should be ignored. In contrast, oncocytic PTC shows diffuse, unequivocal PTC nuclear features.